Both cardiac resynchronization therapy devices, that is CRT-P and CRT-D, provide biventricular pacing to coordinate the contraction of the right and left ventricles. This corrects mechanical dyssynchrony, improves cardiac output, and reduces heart failure symptoms. The primary difference lies entirely in the presence or absence of defibrillation capabilities. CRT-P pacemaker provides resynchronization therapy and pacing for bradycardia. It cannot treat malignant ventricular tachyarrhythmias. CRT-D defibrillator combines biventricular pacing with an ICD. It monitors for VT and VF, delivering anti-tachycardia pacing or high voltage shocks to terminate them. Here is a comparison. Primary goal: CRT-P relieves heart failure symptoms, reverse remodeling. CRT-D symptom relief plus sudden cardiac death prevention. Arrhythmia treatment: CRT-P bradycardia only, CRT-D bradycardia VT and VF. Device profile: smaller and thinner CRT-P, larger and thicker houses shock capacitors in case of CRT-D. Battery longevity typically 7 to 10 plus years for CRT-P, while CRT-D typically 5 to 8 years and depletes faster if shocks occur. Ventricular lead: standard RV pacing lead for CRT-P, and for CRT-D instead of that RV defibrillation lead, single or dual coil. The role of CRT-P in modern practice. Historically, CRT-D was the default choice for most eligible patients because the criteria for CRT, left ventricular ejection fraction 35% or less, automatically met the criteria for primary prevention ICD placement. However, the role of CRT-P has expanded significantly based on recent trial data and a better understanding of competing mortality risks. CRT-P is strongly considered and often preferred in the following scenarios. Non-ischemic cardiomyopathy. The Danish trial demonstrated that prophylactic ICD implantation does not significantly reduce overall mortality in patients with non-ischemic heart failure with reduced ejection fraction. Consequently, for patients with non-ischemic cardiomyopathy and a pacing indication, example LBBB, white QRS, CRT-P provides the symptomatic and remodeling benefits of resynchronization without the added hardware cost and complication risks of a defibrillator. High competing mortality risk: frailty, comorbidities. In elderly patients or those with severe comorbidities, advanced CKD, severe COPD, malignancy, the risk of dying from pump failure or non-cardiac causes often outweighs the risk of sudden arrhythmic death. An ICD might successfully terminate an arrhythmia only for the patient to succumb shortly after to progressive heart failure. CRT-P focuses on quality of life and symptom relief without outliving its benefit. Severe heart failure, ambulatory NYHA class 4. For patients with refractory class 4 heart failure who are not candidates for advanced therapies like LVAD or heart transplant, ICD shocks offer no meaningful survival benefit and can cause significant physical and psychological distress. CRT-P is utilized here primarily for palliation and symptom management. Generator downgrades. When a CRT-D battery depletes, downgrading to a CRT-P generator is a viable strategy for patients who have never received an appropriate shock during the life of the device, particularly if their LVEF has normalized more than 35 to 40% due to successful resynchronization. Pacing-induced cardiomyopathy. Patients who require an upgrade from a conventional dual-chamber pacemaker due to a high right ventricular pacing burden and subsequent LV dysfunction often require only a CRT-P provided their baseline risk for SCD remains low.